Welcome everyone who's joined us
Great.
for this Breeze seminar, acknowledging the funding from the New South Wales Ministry of Health. My name is Professor Martin Holt from the Centre for Social Research in Health, and I'll be chairing today. Firstly, I'd like to acknowledge if you're participating anywhere in Australia, you're participating from Aboriginal land. I'm participating today from unceded Gadigal country, and I'd like to pay my respects to elders past and present, and welcome any First Nations colleagues who are with us today. At this difficult time in the country's conversation about heritage, I'd just like to acknowledge my fellow participants in the session. Dr. James MacGibbon is the lead researcher of the PrePARE project and one of my colleagues at CSRH. He'll be doing the bulk of the presenting shortly. And we've asked our colleagues Tina Gordon from the New South Wales Ministry of Health and Matt Vaughan from ACON to join us as respondents to give some initial impressions. Those of you who may know the PrePARE project will realise that normally this is a survey that we've done every 2 years since 2011. So we're reporting on this year's preliminary findings. We haven't actually released a report yet. So this is kind of a sneak peek at some of the high-level data. And then the report will be made available later this year, and we'll circulate it all to you afterwards. So any feedback or questions are welcome at this point, because that will guide our follow-up analyses and additional reporting. I should note that this session is being recorded, so if you don't like your face being captured or audio, you can keep your camera off. I'd ask that everybody keeps their microphones on mute while other people are presenting. Feel free to use the chat to put in questions, which we'll probably address after James has finished talking, unless they're very straightforward, in which case I may jump in. Without further ado, thank you for joining us. We had a lot of people register, and I can still see people are coming in, but James, over to you.
Great, thanks very much, Martin. I'm just going to share my screen to make sure that's working, and a quick caveat that I think my internet connection is struggling at the moment. So if you notice that I'm freezing or you can't hear me properly, please interrupt me, and I might need to tether from my phone. So my name is James MacGibbon. I'm a researcher at the Centre for Social Research and Health. My pronouns are he and him. And I would also like to acknowledge that I'm joining from unceded Bidjigal land here at UNSW's Kensington campus. I'd like to pay my respect to elders past and present, and to First Nations people who are joining us here today. And I would also like to acknowledge that it's a particularly difficult time for First Nations people in Australia as we navigate this process towards a referendum in less than 2 weeks. So I will start with the presentation now. I'm going to be covering... Here we are. Okay, I'm going to be covering a range of our key measures from the PrePARE project, which has been running since 2011. First of all, the method, sample overview, sex in the previous 6 months for our participants, the use of PEP and PrEP, and then attitudes towards PrEP and dosing strategies, attitudes towards treatment as prevention and to undetectable equals untransmittable, the U equals U message, and finishing with attitudes towards condoms. So as I mentioned, this is a national online survey of gay men, bi, plus, and queer people, and it's been conducted every 2 years since 2011. The participants can include people aged 16 and over since 2021, and it includes non-binary people as well. So the main aims of this survey are to assess attitudes to HIV pre-exposure prophylaxis, as I mentioned, which I'll refer to as PrEP, and attitudes to HIV treatments, including U equals U, as I said. We have also included new survey items each round that respond to, I'd say, current issues in the sexual health sector. So, for example, in this presentation, I'm going to cover the use of antibiotics for the prevention of STIs, and a few other new items which we've included in this round. And in this round, in 2023, participants arrived to our survey mostly by direct email invitation, so 31%. So these were people who had completed either the PrePARE survey at the last round or one of our other surveys, which mostly accounted for the survey we ran last year on Mpox, followed by Instagram recruitment at 31%, Facebook at 25%, and then Grindr at 12%. Now, we saw the biggest shift this round in participants coming from Instagram, so that increased quite a lot, up from 7% in 2021. And our Grindr recruitment actually decreased quite a bit. So we were at 28% in 2021, and this decreased to 12%. So now I'm moving on to the sample overview. So who we have. So first of all, you might see here that our sample size is significantly larger than previous rounds. So we wanted to increase the sample size. And one of the reasons for this is because we've got this increasing group of PrEP users, and we wanted to therefore have a greater number of people participating in our survey who weren't using PrEP, so we can understand what they look like and deepen our analysis into this group of people. And so we targeted a broader range we have started to target a broader range of platforms to advertise and to broaden our sample. In 2023, we also specifically targeted younger people in our advertising strategy. And so it's pleasing to see that our median age over here has decreased to 35 years old. Now, in the next line, most of our sample identified as gay, but we have had increasing numbers of bi+ and queer participants since 2019. In 2023, 5% of our participants were classified as transgender, non-binary, or gender diverse. And 70% of participants were born in Australia. So there's not really been any significant or meaningful difference here since 2019 in terms of people being born overseas. And HIV status also remains unchanged between years, although PrEP use has increased significantly. Now, in terms of STI diagnosis on the final row, we see that they fell moderately in 2021, which likely reflected the time of recruitment and COVID and decreased testing. But this seems to have returned in 2023 to a level more similar to 2019. So in 2023, this was 27%. Now, we'll just mention as well, what's not shown here is that we have a relatively higher educated sample in PrePARE, and that's remained pretty well unchanged over recent survey rounds. And I will also note that of the people who are untested or unknown HIV status, the majority of these people haven't had an HIV test at all. Now, in terms of our sample and where they reside currently, we had 32% in New South Wales, 28% in Victoria, 19% in Queensland, and 21% in the other jurisdictions. So we've seen in 2023 this breakdown actually kind of tend to go back towards what we'd expect from population data, which is good. In the past, we've had much higher numbers in New South Wales, owing to, I guess, our location and also our partnership with New South Wales-based organisations like ACON, helping us with recruitment. And of course, acknowledging our funding coming from BREEZE and New South Wales Ministry of Health. So we've had a greater focus on New South Wales. Half of our participants lived in the metro areas of their capital city, And here we've classified an inner metro area as people living in the CBD or in the postcodes immediately adjacent to the CBD of their capital city. 29% lived in the outer metro, and 20% of participants lived in a regional or remote area. Now, continuing with sample characteristics, in our total sample, I said that 70% were born in Australia. Now, 12% were from Southeast Asia or East Asia, 8% were from Europe, 3% were from Oceania except Australia, 3% from Latin America and the Caribbean, and less than 2% in each of Africa, North America, Central, South, and West Asia. Now, we also in 2023 expanded our recruitment. So we wanted to, so first of all, we translated the surveys into Thai and into simplified Chinese, and we wanted to target people born in Thailand and in China. So we ran advertisements on Facebook and Instagram in both Thai and Chinese, and we had 47 people complete the survey in Thai and 3% in simplified Chinese. Although I will note that of people who arrived to the survey in Chinese or from Chinese advertisements, quite a number of them switched the survey over to English and completed the survey in English. Now, in terms of recency of arrival, we had 19% of migrants in our sample arriving to Australia within the past 2 years or 2 years prior to the survey. And the largest group of migrants was from Southeast and East Asia at 11% of migrants. Now, we'll just flag, as we mentioned in the invite to this seminar, we have a number of analyses planned, and our colleague Simin Yu will be leading an analysis of migrant gay and bisexual men going forward from PrePARE project. Now, in terms of the sex that our participants had in the 6 months prior to the survey, 90% had sex with male partners, including cisgender or transgender partners. 80% of the sample only had male partners, and 7% of the sample reported sex with female partners, including cisgender and transgender women, and 7% reported sex with non-binary partners. And these are similar proportions to what we observed in 2021. Now, here I've stratified our results by HIV status and PrEP use for condomless sex with casual male partners. And there hasn't been much change in the proportion of participants reporting any condomless sex with casual partners in the last 6 months, just in recent years. Condomless sex with casual partners has remained highest among PrEP users, which you see not much change at all, in fact, since 2017, followed by people living with HIV, and then less than 1/3 of both HIV negative participants and untested participants reporting any condomless casual sex. Now, we'll note in the purple line, you see that there's quite a bit of fluctuation in the proportion of people living with HIV who report condomless sex with casual partners. And I'd just like to acknowledge, I guess, that due to having quite small group sizes relative to the rest of the sample, it's not necessarily surprising that we see this much variation, as it might be due to sampling. Now I'll move on. So here we're tracking the use of post-exposure prophylaxis and use of pre-exposure prophylaxis. So in the blue line, we have lifetime PrEP use, and that's increased to 58% in 2023. Current PrEP use has also increased to 46% in 2023. And then we see that lifetime PEP use has remained relatively stable since 2021 at around 1/4 of participants. So that's in the grey line there. Now, next, I've stratified these results by age, dichotomized into people who are younger than 30 in the dotted lines, and the rest of the sample who were age 30 plus. So we see that lifetime PrEP use and current PrEP use have remained higher among people aged 30 years and older. So there's a gap in current PrEP use where it's about 14% lower among people aged 30 years and old. Now, rather than kind of get into all of the differences between PrEP users and non-PrEP users, I'm just going to put in a little bit of a shameless plug here. If you're interested in variations in prevention coverage, we've recently published a much broader analysis in AIDS and behaviour. And this paper is available open access, so you can either scan the QR code or perhaps we can pop the link in the chat at some point. But you'll see a much more in-depth analysis of differences in prevention coverage in Australia from community periodic survey data. So now back to PrEP and the PrePARE survey. I mentioned that there's a widening gap between lifetime PrEP use, people who've ever used PrEP, and current PrEP use. And in 2023, there were 379 participants who'd stopped PrEP either temporarily or permanently. Now, since 2019, we've been asking these participants who'd stopped PrEP what their reasons were for stopping PrEP. And these participants could select multiple reasons. Now, since 2019, the most common reasons have remained the same. So they were having less sex at 49% in 2023, or that they had entered into a monogamous relationship. Now, the other reasons are listed here with less than 20% each. They were people who had side effects from the medication. They felt that they were no longer at risk of HIV. They couldn't afford it at 15%. They ran out of pills or didn't have a prescription at 14%, or they were concerned about taking medication at 12%. Now, moving back to the current PrEP users, this graph shows changes in PrEP dosing since 2017, which is the line in blue, compared to 2023, which is the lines in red here. So we've seen a pretty steady decrease in the proportion of PrEP users taking daily pills, which is over on your left side of the screen, which seems to have had a bit of a steeper drop-off in 2021 after a period of COVID restrictions. And in turn, we've seen that the proportion of PrEP users who are taking PrEP on demand or event-based dosing has steadily increased from 1% only in 2017 up to 18% in the last round in 2021 and now 29% in 2023. And we've had much smaller proportions of PrEP users report that they've been taking PrEP using periodic dosing or another way. Now, moving to the first of our scales from the PrePARE project. The first is willingness to use PrEP, which is derived from a 7-item scale, and concern about using PrEP, which is derived from 2 items. Now, the concern about using PrEP scale revolves mostly around worry about side effects and worry about taking PrEP on an ongoing basis. Whereas the willingness to use PrEP scale includes things like being willing to take PrEP to prevent getting HIV, being willing to pay for PrEP, and an item such as I'm going to take PrEP as soon as possible. So it's a broader kind of selection of items. Now, willingness to use PrEP has remained stable on this measure since 2019 at 32% of participants who had never taken PrEP. And concern about using PrEP decreased from 46% in 2019, but it's remained relatively stable between 2021 and 2023. Now, moving on to another way of looking at these data, we've developed a PrEP cascade to assess uptake across a range of measures, starting with eligibility, or suitability, as we say in the newer PrEP guidelines in the first step. So I won't go through all of the steps in detail, but I will first kind of explain that 2023 is represented here in teal, and the 64% here indicates that 64% of participants who were HIV negative or untested for HIV at the time of the survey were deemed eligible for PrEP according to our approximation of the eligibility guidelines, or the PrEP suitability guidelines. And that then 63% of that group were eligible and aware of PrEP. So we see, almost ceiling levels of people who know about PrEP. And then we have a much larger decrease in willingness to use PrEP at 55%. So this is not all bad, however. In fact, it's very promising. We've seen improvements in each step in each survey round. So when we go down to the proportion of people using PrEP, we see that 72% of PrEP suitable participants are using PrEP in 2023, and that's up from 64% in 2021. So here I've calculated these proportions in a slightly different way. And we see that 87% of PrEP suitable and aware participants were willing to use PrEP, and that's up from 84% in 2021. So I'd encourage you, if you're interested in this, we'll be publishing a version of this in our report, and then looking further at this in another analysis coming in the next year or so. Who are recently tested for HIV and STIs is actually widening. Now, that we would assume is due to more people taking PrEP on demand, and therefore not necessarily needing to see their physician as regularly, and certainly not every 3 months as we've used as the period in this cascade in the past. So that might be something that we revise. Here we're looking at people who we've classified as being suitable to take PrEP, and that's a group of 250 or so people, 251 in 2023. And we've asked them what their reasons were for not taking PrEP at the time of the survey. The most common reasons were not having enough sex at 39%, not being comfortable talking to a doctor at 34%, that they were using condoms at 33%, concern about side effects 32%, concerns about long-term medication use at 30%, or not knowing how to get PrEP at 29%. So these were not mutually exclusive reasons, obviously, to achieve these proportions. Yes, so we also asked this same group of people and others what their most preferred way to take PrEP would be if they were to take PrEP. Now, the most commonly endorsed ways to take PrEP were monthly pills, if they were available and equally effective, that is, event-based dosing, and then long-acting injections, implants, and daily pills. So it's interesting to see that daily pills, obviously the most common way to take PrEP currently in Australia, was the least popular among this group of PrEP suitable participants who'd never taken PrEP. Now, in the past, we've also been asked what this group of PrEP suitable participants looks like, and whether they had any characteristics that stood out. Now, we've looked at region of birth, and really there's no difference here between this group and the rest of the sample. We've looked at age group. They are younger. There's a greater proportion of under 30s. They're more likely to live in rural and remote areas, but not more likely to live in the outer metro area. They have similar levels of Medicare coverage and similar similar proportion being students. They were, however, more likely to identify as bi plus. Of these people who've been classified as suitable to take PrEP, 70% or 77% reported condomless sex, and 20% had had an STI diagnosed in the previous 12 months. Okay, so now moving on to another new measure in 2023, we asked participants who were recently taking PrEP about their access to PrEP and potential side effects. So we saw that of side effects such as nausea or just getting general side effects, less than 15% endorsed both of those items, or 11 and 15%, I should say. And we asked people if they struggled to pay for PrEP or how their access was in terms of affordability and access. And that ranged. So we had only 17% say that it was challenging to find a doctor, and 73% saying that getting PrEP was easy, and 66% saying that sexual health appointments were affordable, 56% saying that PrEP is affordable. Now, this is interesting, but I should note that we have quite high income ranges in PrePARE. So in the total sample, more than half of participants had incomes over 80,000 Australian dollars, and 25% over $120,000. But of current PrEP users, more than 60% had incomes over $80,000, and 32% had incomes over $120,000. So there's definitely room for a more nuanced analysis of what's or the association between income and access. But yeah, I won't sort of go into that much more here, but there's food for thought anyway. Now, quickly just comparing preferred dosing strategies of PrEP users, there hasn't been much change in terms of both groups of PrEP users and non-PrEP users preferring monthly pills and long-acting injections. When we start to see a difference, it's that event-based dosing seems to be much more preferred among non-PrEP users compared to existing PrEP users. Daily pills is lagging again, as we saw in the previous slide, looking at people who had never used PrEP but were deemed as being suitable to take PrEP. Now, here we're looking at willingness to have sex with men on PrEP. So this is another measure derived from previously a 3-item scale. And now we've revised that to a 2-item scale. Now, what I've done this year is taken out one item, which was about people being willing to have condomless sex with PrEP users. So when we've taken that item out from the scale, we see that the scores on the scale have increased quite drastically. So over on the right here, I've got the original scale with the 3 items. And here I've got the 3rd item taken out and in a dotted line. Now, I don't really have time to go into this much further, but I would say that if it's something that interests you, to have a look at the discussion of this measure in the report when it's released later in the year. Now, this is another of those scales which we have asked of PrEP users and non-PrEP users who are HIV negative or untested. And what we're asking is whether they report reduced HIV concern from using PrEP or in general from PrEP being available in the community. We haven't seen much meaningful change in these measures since 2021. And again, I'm not going to get into detail of this measure, but signal that you can find out more about it later in the year. Now, we've also been asking about belief that HIV treatment prevents transmission. And we've we've included this scale in the survey since 2013. So with 10 years of data, we've seen that belief in treatment as prevention has increased overall, but it's plateaued in recent years among people living with HIV and HIV negative participants between 2019 and 2023. Now, I've also removed one item from this scale and recalculated the scores, but again, that's something that if you're interested in, you could read more about in our report later in the year. Now, in 2021, some of you have been following our work will know that we introduced an item about familiarity with the undetectable equals untransmittable message. We also asked people who had heard of this message how accurate they believed the message was, and separately we asked people if they'd be willing to have condomless sex with a person living with HIV who had an undetectable viral load. Now, the majority of our sample were familiar with U equals U, a lesser proportion believed it was accurate, and a much lower proportion were willing to rely on U equals U. And side by side, I've got 2021 and 2023 data, and you'll see that there's really not a lot of difference between the two survey rounds. Now, again, here I've stratified by PrEP use and HIV status, and the dotted lines are the previous round, so I think you could probably ignore them, except to note that you've got a lot of similarity between the two rounds. The main purpose of me showing you this is to show that people living with HIV had the highest levels of familiarity, belief in U equals U, and willingness to rely on it, followed by PrEP users, then HIV negative participants not on PrEP, and then untested or unknown status participants. And again, this is something we've published on quite recently in the Journal of Sexual Health. So if you follow this QR code, or if you ask us, we can post a link to this in-depth analysis in the chat as well. Now, getting toward the end, I've got a few more slides to go, but one of our legacy scales is also confidence discussing condoms. Now, we've seen that on this measure, we've had scores kind of plateau among PrEP users and people living with HIV since 2019. But we see some promising results that confidence discussing condoms has actually increased among other HIV negative participants and untested participants since 2021. Now, changing pace a bit to look at STI diagnoses and testing in the last 12 months, or 12 months preceding the survey. Now, what's not shown here is that 85% of the total sample had ever been tested for STIs, but you'll see that much greater proportions of people living with HIV and PrEP users had been tested for STIs and had also been tested within the last year compared to other HIV negative and untested or unknown HIV status participants. Any STI diagnosis in the last year was most common among PrEP users, followed by people living with HIV, then HIV negative participants and HIV untested participants. Now, I haven't given results of specific diagnoses for each of these groups, but looking at everyone who had been diagnosed with an STI, the most common STIs were chlamydia at 64%, followed by gonorrhea at 51% and syphilis at 17%. Now, for a new item, which is, I think, very timely, or I will get to that actually. In 2021, we've asked about acceptability of different STI prevention strategies. Now we see not a lot of change in terms of condoms being acceptable, but and the same with regular low dose antibiotics, which we would call STI PrEP. But we've seen a slight increase in interest in antibiotic pill after sex which would be STI PEP or doxy PEP. Now, here we are, specifically interested in what's happening with doxycycline and the results of recent trials, which have been showing promising findings for bacterial STIs, particularly for syphilis. Now, we, moving to the next slide, asked everybody if they'd ever used antibiotics for STI prevention. We didn't specify doxycycline specifically because we wanted to know if perhaps people had used other antibiotics of the same class of medicine, and perhaps not in a regulated way. So 8% of our sample had used antibiotics for STI prevention, and we then asked everybody if they were familiar with antimicrobial resistance as a concept, and 42% had some familiarity, and anyone who was familiar in some way, we asked if they were concerned about antimicrobial resistance, and 76% told us that they were, which I don't find particularly surprising for a range of reasons, but we don't need to get into that here. Now, of the people who had taken antibiotics for STI prevention, so that's 157 people in our survey, about a third had stopped permanently and about a third had stopped temporarily. 19% told us that they were taking doxy PEP, so antibiotics after sex, and 8% told us that 19%, I hope I said, were taking doxy PEP, and 8% were taking doxy PrEP, so low dose antibiotics or one pill perhaps every day. 7% told us that they were taking antibiotics another way. Now, of these people, about half said that they had had their antibiotics prescribed by their doctor, and 37% had used antibiotics that they'd already had. And these, again, weren't mutually exclusive categories, so people could select multiple ways that they'd perhaps obtained these antibiotics that they'd used to prevent STIs. Now, when looking at lifetime antibiotics for STI prevention, and comparing by each of our groups, there was higher use of antibiotics for STI prevention among people living with HIV and PrEP users compared to the other two groups that I've covered in depth already. Now, another item that we've added in the 2023 survey is around HIV status discussion and disclosure. Again, it's not something I'm going to cover in a lot of detail here, but I'll signal what kind of results we have and what we'll be looking at further in a more nuanced analysis. So of people who were sexually active, which is just shy of 1,900 participants, 80% reported that they had sex with HIV negative partners, 64% said they had sex with PrEP users, 13% with people living with HIV, and 15% with untested partners. Now, 9% of participants said that they didn't know the HIV status of any of their sexual partners, and I haven't yet looked at the HIV status or PrEP use stratification for that group of people. Now, we asked people also about what they expected of their sexual partners, and specifically about disclosure of HIV status. 75% of participants said they expected a person with HIV to disclose, compared to 44 to 48% who expected PrEP users or other HIV negative partners to disclose that they were taking PrEP or to disclose that they were HIV negative. Now, what's interesting here, of course, is that although there's this perhaps an expectation to disclose or to know partner's status, we know that that around 36% of participants reported always knowing their partner status before sex. So there's certainly a difference between an expectation and perhaps practice for various reasons, particularly for our very large group of PrEP users in this survey who perhaps might not feel it necessary to know their partner status. Right, so I'm going to sum up now, just reflecting on all of the various different things that I've discussed over the past 40 minutes. So recent PrEP use in the 2023 survey increased 46% of our sample. There was an increase in event-based dosing to 29% in 2023. Willingness to use PrEP was stable at 32% and it has been since 2019, and concern about using PrEP was at 37% of participants who had never taken PrEP. Barriers to using PrEP remain not wanting to talk to a doctor, not having enough sex, concern about side effects of the medication. Now, of the PrEP suitable participants that we talked about, they were slightly younger, more likely to be bi plus men and people living outside, actually not outside in metro areas, and more likely to be living in regional or remote areas. That's incorrect on this slide. To stopping PrEP, that was associated with having less sex or entering into a monogamous relationship. We saw that there was strong interest in alternative dosing strategies, especially in longer acting types of PrEP. We saw that belief in treatment as prevention and awareness of undetectable equals untransmittable message remains concentrated among people living with HIV and among PrEP users. Confidence discussing condoms with partners has increased among HIV negative participants not on PrEP and untested participants. There's strong interest in use of doxycycline for the prevention of STIs, and there's some evidence of existing off-label use in our sample at 8% of participants. There's strong expectations for HIV disclosure, but a gap between expectations and practice. Now, finally, I'd like to acknowledge all of the participants who completed the questionnaires, not just this year, but over many years now. And I'd like to acknowledge the work of the current and former members of the PrePARE project reference group. Now, the PrePARE project has been funded by Breeze at New South Wales Ministry of Health, and we also receive funding from the Australian Government Department of Health. And finally, here's the website for the study, where you'll find those publications that I've mentioned, except for the shameless GCPS plug. And here are my and Martin's email if you'd like to contact us to discuss anything. But I'd love to move on to hearing your thoughts, and in particular to hear from Tina and Matthew. So thank you.
Thanks, James. Well recovered with technical glitches. I've also noted some people in the chat with direct messages that the report is coming later this year. And as long as people don't mind, we'll probably send a link to it to people who've registered for this session, so that you'll get a link to the report later in the year when it's ready. James, that was great. I don't know if you want to keep the slides up or to stop sharing. It's kind of up to you. And I might go for initial reaction. Matt, can I put you on the spot, and then Tina, I'll come to you. Was there anything that jumped out at you or that you would like to talk about a bit more? And then I'll also go through the group chat as well, see if there's some, invite people if they want to comment as well.
Yeah, look, I've picked up a couple of things, and I've probably got like a page full of notes. So thank you, James. I was like, oh, I better write a few of this down, because one, it's going to really inform the way we're starting to shape messaging, but also just thinking about, you know, the future work that we have with campaigns. And I think there's a couple of elements that really relate to PrEP, particularly around, you know, the willingness around non-daily options and the way that that's dropped over time significantly from being the only option to now, you know, the attractiveness of both on-demand PrEP or event-driven PrEP, but particularly that monthly peel. And I think a lot of that also relates to, some of those barriers that people kind of experience with monthly PrEP around the doctor, the side effects, and, sex not warranting taking medication would really be resolved by that idea of a 1 pill a month option that makes it much more justified. It's really interesting to see the gap in the cascade. And, I think we do quite a good job, particularly in New South Wales, around educating people around PrEP and how it's going to work for them, and the different dosing regimens, and how that can be suitable for depending on the frequency and the types of sex that you can have. But what I was really interested in is the particular cascade around the familiarity and for U equals U. And I think this is something that's really a big piece of work that we need to unpack as a sector, is that awareness of and belief of U equals U, but then the idea of putting it into practice. And I know that this has also come up in the chat as well. I think this is obviously a legacy piece of stigma, and, 35 years of driving people around, fear of HIV to a certain extent, or being cautious of HIV, and now starting to unpack that. And, I think as a health promotion person and, a lot responsible for a big part of ACON's messaging in this space, I think that's something that really the onus is on a lot of our community organisations to start going, okay, how do we start doing that? It's going to be incremental changes, and it's not all going to be through social marketing or campaigns, but tackling that, not just from I think often when we're looking at U equals U messaging, we kind of go, oh, yeah, we've got a high uptake of people on treatment. And so we don't necessarily need to do a lot of messaging around U equals U or treatment, but it's actually around the stigma reduction angle and belief for negative guys and PrEP users on having confidence around U equals U. And I don't have the answer on that, but I'm sure there'll be a lot more learned people than I do. Those are just my initial quick reflections.
Thanks, Matt, and thanks for picking up some of the comments in the chat, which were about the U equals U, and always triggers people's attention about whether, and I sense that most people just want to see, would love to see 100% confidence in the message, and the data clearly show that that isn't the case. I have a slightly different view, that looking at the sex with data, like, so who the participants say they have sex with, they're not avoiding people. If you think the sample only has 7% people living with HIV in it, but 13% of the sample reports sex with positive people. So actually, positive people are overrepresented as sex partners in the sample, given the population prevalence. But so that doesn't suggest avoidance in the sample, although there are some other things going on in there, like there is a preference for PrEP users as partners in this particular sample as well, which does suggest some maybe preference for people using biomedical prevention methods. Tina, can I come to you on any thoughts or questions? Then we'll open it up.
Thank you. And firstly, thank you to James for such a great presentation, and also James and Martin for the 2023 survey, and for everybody who was involved. Engaging over 2,000 participants was a great result. So, the type of things, some of the things that I picked up on were actually quite similar to Matthew. So, the ministry has been supporting PrePARE for quite some years, and it really provides us with some rich information on activities and preferences of the survey participants, and it helps us really identify areas that we need to change for the New South Wales HIV policy response. So, the type of things that we're looking at are like issues or barriers to prevention methods and PrEP usage, who's responding to the survey as well, and what their preferences are, and what the changes and beliefs are around prevention methods such as U equals U and treatment as prevention. So for this year, the expanded recruitment, having the survey available in Chinese and Thai, I thought was really interesting, even though James did mention that I think some of the Chinese swapped to English. So that, yeah, thought that was interesting. The New South Wales HIV response. At the moment, we really have quite a renewed focus on populations living with or at risk of HIV in outer metro and regional areas. So it was interesting to see overall in Australia those areas were pretty well represented. I think it was like nearly 30% for outer metro and 20% for a regional or rural. So that yeah, it's nice to see a whole of New South Wales response there. Look, the areas that some of the new survey items as well, particularly to the responses to STI prevention through the Doxy PrEP and Doxy PEP and PrEP. It's very timely for New South Wales Health, particularly, Martin, as you noted, with Asham's consensus statement just coming out last month as well. So we're still at a stage of reviewing and assessing what our policy responses might be to that. So look, I'll leave it at there for the moment. But look, thank you again to everybody who was involved with the survey. Really look forward to it being published later in the year.
Thanks, Tina. Thanks for that response.
Thank you.
And yes, I'll note, having taken part in the Asham consensus statement, I'm going to put scare quotes around it because, like, it was an interesting process and quite a range of views about the use of Doxy PEP. Although it feels like, I think this is kind of a useful reminder that it's already happening, and that perhaps us getting on top of that and guiding it and making it safer and more effective is probably what we need to be doing, rather than pretending it isn't happening. Are there any other comments or questions? I've noticed my interpretation is that some of the comments in the chat have been picked up by James and by Matt and Tina already, but is there anyone who's commented who would like to ask a question or make an additional statement? Please feel free. Oh, and yes. And please unmute and ask your question.
Oh, hello. Hello,
Hi.
James. Thank you so much. And Martin, thank you so much for your presentation. That was really in-depth and I learned a lot from it. I do want to have a question around the way that you collect demographic information, because I work with a lot of people from different cultural backgrounds and people who are second-generation migrants. And there's an understanding that culture kind of plays a role within how people perceive HIV prevention and have HIV prevention methods. I was wondering if there are any plans to capture people's cultural background for like Australian-born people within this data, because I think that'll be very interesting to see, you know, the kind of ways that one's cultural background also impacts their kind of understanding.
Right.
Yep.
So that question, James, you may have a comment here. We did add some more, and I'll acknowledge we don't do this in a great way sometimes, but we have a few more, anticipating that we might be looking at migrants in particular, but acknowledging that people from different cultural backgrounds who've always lived here, that's a different group and an important one to understand. We've got, I'm not sure how we ask about ethnicity or background in the survey. James,
we don't currently ask about ethnicity, and it's something that we considered to include this round. We hadn't got the question quite right and didn't. Yeah, I think we didn't leave enough time to workshop that. So it is something that we're considering, and certainly something that we can look at much more closely next time. And it might be part of the broader work that our colleague Simin Yu does in considering what we're missing in the current survey to answer some of these questions that we're thinking about.
So I will flag, and we don't want to throw Simin under the bus too much, given she is a PhD student and a research assistant. But we do plan to look at, because it's already recognised in New South Wales and elsewhere, we will look at recently arrived migrants. We obviously had the focus on trying to engage Chinese and Thai speakers. We did ask about language spoken at home as well. But that still, I'm just acknowledging, does not get at someone who's grown up in Australia their whole lives but comes from a different cultural background or culturally and linguistically diverse background. It goes some of the way, but not all of the way. We've got more of a focus this round on migration status. And then, but I'll take that on notice that cultural background and diversity is an important consideration as well. Thank you.
Amazing. Thank you so much, Martin and James.
Does anybody else want to? Oh, I've now
There are a couple of questions in the chat that I'm happy to kind of try and address.
Yeah.
The first one is from Dennis, and I don't know what you're referring to in terms of the table. Let me look at people on prep table at the beginning. But if you'd like to unmute and
yes, absolutely.
ask a
Hello.
question, yes. Hi.
Yeah, it's Dennis Quinter from Education at the Albion Centre. I just noticed in one of the tables at the very beginning, one of the groups was actually people living with HIV on PrEP. And I don't know if I've misread it, but I was trying to work out what does that actually mean? Is it, treatment as, a prevention through treatment, like U equals U? Like, why would a person who's positive be on PrEP? Is there a situation?
No, we haven't covered PrEP use among people living with HIV. So that's not, not something that was included in the survey.
Dennis,
Oh, okay.
I think when we, I'm just going to guess that you were looking at the participant characteristics table, which was quite busy.
Yes.
And James, we currently split up, so we have people living with HIV as a separate group, all of them, and then we have PrEP users as a separate group, and then negative guys who are not on PrEP and untested unknown status participants as well. So I think maybe you just saw those next to each other, like the PrEP users.
Yeah, that would be it.
Yeah.
Oh, okay, great, thank you.
Yeah, no worries. Dean, you have your hand up.
Yeah, just in regards to your engagement with cold groups and participants, how do you approach that in terms of looking to strengthen that engagement and recruitment? Do you rely on local talent, or do you have partnerships with, organizations in these countries to get advice? I'm just curious about how you actually do that.
So I will just note that this was, we had mooted some recruitment in language for different non-English speakers for a few years, and we dodged it 2 years ago. So we decided this year was the first year we had to do it. And that's why we only did 2 language groups. And we worked with partners and peers through ACON. We have links to multicultural HIV as well. But for this particular round, we had Mandarin and Thai speakers from ACON all within our research team. It wasn't a big, and we circulated the recruitment materials and the questionnaires through them, and we were kind of very conscious. And then we did a bit of arm's length peer testing as well. So people we knew who were Thai speakers, we said, can you send these materials to some of your buddies and just read through it and point out anything that doesn't make sense. I think James will acknowledge, we felt we were running a bit late this year, and if we'd had more time, we would have done a longer process through some of our networks and possibly a broader range of language groups as well. It's quite, as I'm sure you understand, like, to do it properly actually takes quite a lot of time. And we already know, like say our Thai version of the questionnaire, there are terms in the English version that don't translate into the Thai version because there aren't equivalent terms. So we had to make some decisions about what we included then. I hope that answers your question. Now, I'm aware people may need to start leaving, but I'm happy to stay on, James, if you are, in case there are any outstanding comments or questions. But if you need to go, thank you for attending. And we will hopefully, with a bit of editing of the blooper in the middle where we dropped out, we will make the recording available as well. I'll also note that if you have a question you were too shy to ask, please reach out to me or James, and we can try and clarify for you. Any final comments or questions? And otherwise I may then go back to Matt and Tina. I will flag, James noted that we have a list of potential analyses. So this was kind of the headline data, like the main results in the whole survey in most of the survey domains. We plan to turn some of these into peer review publications as we go, and the report will come out first as well. The report will inevitably have more detail than this session. If there's something in the data set that would be useful to you in your work, or because you're also doing similar research, please let us know. We're very happy to focus on a particular aspect of the survey if you're planning health promotion work or programs, or if there's something that would help illuminate something for you. I'd like to go back to Matt. Any final words from you or thoughts?
I think the only things that I'm just scanning through my page is, what's really surprising, and I think it really aligns with what gets picked up in the GCPS. So there's always that 9 to 10% of people that are kind of negative or untested or unknown. And it's really interesting that we never see that change at all. Like in the last 20 years, it's remained pretty much almost the same, maybe fluctuating to like 13 or 15%. But I think the other one was that kind of 28% of people that untested, unknown, and engaging in condomless sex. And, to go back to James's free plug on the characteristics paper from GCPS, like I think that increased when you looked at young people under 25 to like 40%. And I know that we had a conversation about this yesterday, but I think that's the other side, that as a kind of health promotion person, that really is a very confronting figure. And kind of, although we're not necessarily seeing it coming through in HIV data, there's this, very real possibility, particularly amongst young people, but the other characteristics there of sitting and going, well, these are community attached people that are negative that are untested or unsure, and, engaging in condomless sex. So that's a sobering thought that, job's certainly not over yet, that's for sure.
Yeah, thanks, Matt. Tina, any thoughts from you, or things that you'd like to us to delve into a bit more?
Well, Matthew's given me a challenge to look over my notes, but to be honest, I think I'm going to have to do that offline. My writing's appalling. So look, nothing more from me at this stage. Thank you very much.
Thanks, Tina. James, I'm going to give you the final word. You did a lot of heavy lifting there. Is there anything you'd like to note or add before we thank everyone?
There's probably not a whole heap, but I would, I guess, encourage everybody to email me if you have any questions. I'm more than happy to discuss anything that we've covered today with you. Yeah, that makes this worth it, to know that these data can be used and help you in your work. So yeah, don't hesitate to reach out.
Great, thank you, James, and really well recovered there in the middle. That's usually a nightmare for people when the technology fails.
That's right. Lucky I've got 5G on my phone.
Indeed, you might need to make a report to UNSW IT, I think. Thank you, everyone who joined in and who contributed to the chat as well. I'm sorry if we didn't get to your specific comment or question, but I can see there's been some interaction there. It's really heartening to see the interest in the project. It's obviously been an extraordinary period of change in HIV prevention over the last decade, and nobody saw that other pandemic coming as well. And these data definitely reflect some of that flux and change. Please look out for the report. We'll send it to you when it's ready, so you don't need to worry about that. And if you think about something later that you'd like us to dig into or look up, please reach out. And I'd like to acknowledge the broader, as well as James's sterling work as the lead researcher on this, everybody who supports the work through the reference group and is supportive of the project. And of course, our dear funders, both in New South Wales and the federal government. Thank you, everybody, for joining us, and I wish you all the best for your afternoon.